Good afternoon. This is Henrietta Awo-Oseanto at the National Academy of Medicine. Welcome to the second webinar in the Improving Care for High-Need Patients webinar series. This series is an extension of the landmark NAM special publication, Effective Care for High-Need Patients, Opportunities for Improvement Outcomes, Value and Health. The webinar series showcases successful models of implementation of care for high-need patients from around the nation. Today's webinar features Health Quality Partners' Advanced Preventive Care Model for elderly patients with complex care needs. Our featured speakers for today are Dr. Ken Coburn, President and CEO for Health Quality Partners, who will describe the components of the model and lessons learned from its implementation. He will be followed by Dr. Jonathan Harvey, Chief Medical Officer of Martins Point Healthcare, who will share his organization's experience implementing the model. Before we proceed, I would like to note a few housekeeping items. First of all, you can participate in the discussion by going online and using the Twitter handle shown on the first slide of the presentation. Secondly, please mute your phone during the presentation to minimize any background noise. And finally, you can submit questions at any time during the presentation by typing your questions into the box in the bottom right corner on your screen. The speakers will be answering questions during the last 15 minutes of the webinar. So the special publication and the webinar series are produced in partnership with the Peterson Center on Healthcare. I will now hand it over to Emily Zaborowicz, Associate Director at the Peterson Center, to provide an overview of the special publication, as well as other initiatives at the Peterson Center for High-Need Patients. Emily?
Thank you, Henrietta, and to the National Academy of Medicine on your continued work to promote learnings from the High-Need report. Next slide, please. For those of you who may be unfamiliar with the Peterson Center on Healthcare, I just wanted to provide a very quick overview. We're a private foundation, and our mission is to identify proven solutions that improve the quality and lower the cost of healthcare and accelerate their adoption on a national scale. We have three major focus areas. The first is our work to spread and scale high-impact care delivery models. The second is developing best practices, resources, and tools for various stakeholders to improve the environment for the adoption of these models. Lastly is tracking the performance of the healthcare system to ensure that we're able to measure improvement. In terms of the care delivery models in which we invest, we know that there are multiple bright spots across the U.S. where healthcare is achieving, and specific models are achieving better outcomes at lower costs. And we invest in identifying those exemplary models, working with partners to create efficiencies, and designing a scale strategy that can then be executed. Our focus on people with or individuals who have complex health and social needs really stems from seeing tremendous variation between the health outcomes that are achieved and the amount we spend for this patient population. All too often, our healthcare system is failing those who need it most. Next slide, please. So in early 2015, the Center formed a partnership with the National Academy of Medicine, the Harvard School of Public Health, Bipartisan Policy Center, the Commonwealth Fund, and others to partner and really understand how we can better address this variation and improve care delivery for high-need patients. We knew that developing a better understanding of this heterogeneous population, the care models and attributes that need to be tailored to their specific needs, as well as the policy solutions needed to ensure sustainability and further scale up would really be essential to improve the outcomes for these individuals. But before I discuss some of the high-level learnings, in the next slide you'll see our planning committee led by Peter Long, who I want to especially thank. They participated in countless planning sessions and discussions on really how to shape the workshop and the final report that could become actionable for users. So what did we learn? In the next slide, you'll see kind of a starter set model of a taxonomy approach. And what we learned is that high-need patients are diverse and have varying needs. That a taxonomy to segment patients, such as this example, can lead to better informed and tailored care. And across medical groups, it's also important to realize there's a significant interaction of risk factors that have implications on outcomes and healthcare spending. So that's very important to assess at the point of care. In the next slide, you'll see how narrowing in on the clinically meaningful segments allowed us to assess what models already exist that have been shown to improve outcomes and lower costs adequately. We did a taxonomy crosswalk, as you'll see, and the model that Ken will be speaking about with health quality partners that fits across the multiple chronic, major chronic disease groups. So the report, also for those who are interested, also shows a lot of common attributes across models, and what we're interested in is investing in understanding how they can actually be implemented across diverse contexts. Next slide, please. So, with a better understanding of what works to improve care for high-need patients, we're especially interested in building the capability in the field for the how. How do we implement these models? How can they be adapted for scale and more diverse contexts? We're working with the Commonwealth Fund, the John A. Hart Foundation, the Millbank Memorial Fund, Robert Wood Johnson Foundation, the SCAN Foundation, to build knowledge on this how, one way through the Better Care Playbook, which is an online resource developed with the Institute of Health Care Improvement that provides a lot of resources and tools that we hope users can practice in their own care settings. We're also thinking through with partners how to support some of the scale-up of proven models, such as those listed in the preceding slide. That's kind of all we wanted to give an overview of the report and the Peterson Center on Healthcare. And with that, I'd like to introduce Ken Coburn, President and CEO of Health Quality Partners. Thank you.
Thanks, Emily, and thanks to the team at Peterson for supporting this work, and for the National Academy of Medicine group for giving me the opportunity to share some of our work and experiences. I'll be describing the development of an advanced preventive care system that is a nurse care management model for complex chronically ill older adults. And we specifically have chosen the operative name advanced preventive care because it's to be effective, it's essential that these models can prevent avoidable complications of aging, chronic disease, and other risks to health. This slide is highlighting who we are at Health Quality Partners, a 501c3 nonprofit located in Doylestown, Pennsylvania. We've been engaged in our work for about the past 17 years, and I think we have a fairly unique mission, which is to focus on the R&D that's required to design systems, test, and improve them that have an opportunity to be a different kind of care delivery model that's going to impact positively health outcomes for vulnerable high-need populations, especially the older adult population with chronic conditions. Next slide, please. These are some of the partners and projects we've had the opportunity to work with. The top part of the slide indicates those that are current projects underway. You'll be hearing more about our work with the Martins Point Healthcare team a little later on in the webinar, and their effort to adopt the model and implement advanced preventive care. We also have the privilege of working with Doylestown Health, which is a progressive community-based health system, to help them develop population health management capabilities, including the use of the advanced preventive care model. We've had a long-running collaborative relationship with the Camden Coalition and the National Center for Complex Health and Social Needs, focusing on the design and replication of models of care for complex populations. We have a great partnership with Salvio, which is a care management subsidiary of St. Luke's Health, which is a secondary health plan in Tasmania, Australia, that's in the process of adapting our model and implementing it for their high-risk members. We've really benefited hugely from a research collaboration with the University of Pennsylvania New Cortland Center for Transitions and Health team led by Dr. Mary Naylor. And with our partners at H-Metrics, we've had the opportunity to develop IT tools specifically to support this type of work. Some of the other projects listed in the bottom of the slide I'll mention as we talk about some of our results to date. Next slide. So the main thing that I'm going to describe is what I think are the core elements to thinking about the design of models like this, and ours in particular, but I think it's very applicable to other models of complex care for vulnerable populations. And there are a lot of the mechanics around the operations that I could describe, for example, caseloads, staffing, so just to give you a little bit of a flavor of that, because that's not going to be the focus of my comments. But in our model, it's a community-based model led by nurse care managers, RNs. It follows the patients longitudinally and sees them infrequently in person, either one-on-one or in groups. Includes home visits, follows them through all levels of care. The target population is chronically ill, older adults with multiple chronic conditions. Frequency of contact varies based on the need of the patients, but on average is about 30 contacts in a year. About 60% of those are in person, either in the one-on-one setting or in group models. And there's a significant amount of training involved for our nurse care managers. We have a management oversight structure that includes what we call senior clinical leads, who are experienced nurses who become very expert in the model and are able to teach and coach and mentor nurse care managers out on the front lines. And it's a fairly intensive model, high touch, longitudinal. Most patients only are disenrolled either when they die or move out of the area. There's a very small percentage of voluntary disenrollments for folks that decide not to continue to participate. But those are just the kind of the operational mechanics. I think the core elements that we feel have led to successful effectiveness of the model really relate to setting the right aim and this framework that I'll describe now. So the aim is really singularly to improve the health and relieve human suffering, improve health outcomes of vulnerable populations. The approach we take is really one of using systems and design thinking to create the model, and I won't be able to go into a lot of detail about how we do that, but over the years it has become increasingly important to think about how to apply that discipline. And if I had to sum up the model in one sentence in terms of what the logic behind it is, it would be this one on the slide here: to reliably and proactively deliver a set of preventive interventions for high risks that are underreported or inadequately addressed in a manner that is valued by the participant, builds a positive relationship, and improves health outcomes. So kind of in a nutshell, that would be the logic basis for this. And as you'll see, we think there are a great number of very important health risks that fall into this category of underreported and inadequately addressed by our current system, for which there's a huge opportunity to be effective. Next slide, please. So one way to think of this would be a combination of the elements that people might be familiar with around the care coordination, combined with chronic disease management, looking to ensure that best evidence-based health care is provided for certain specified chronic conditions, personalized prevention, which includes a variety of lifestyle interventions and behaviors, and what I'll call, for lack of a better term, system failure duct tape, which is to volunteer to be accountable for the risks to health, both the social determinants and others, that Right now, our current system doesn't have an identifiable party that accepts accountability to try to address on behalf of vulnerable populations, and to try our best, as imperfectly as it is sometimes, to fill that need and to take that on as an explicit obligation of the model. And there are many examples of those failures that I'm sure folks are familiar with, both due to fragmentation of our own healthcare systems and social service and community resources, as well as economic and social stressors that patients and their families are under. Next slide. The use of design principles is something that, whether in our model or others that you're working on, I highly recommend people give thought to using. We have found it incredibly powerful, not as buzzwords to describe what we want our model to do and to provide, but as touch points to use when we work with our own staff about whether we're delivering what we intended to in the model. And these are particularly relevant for situations where protocols and policies and procedures don't fill the gap, don't fill the need. We have lots of protocolized, standardized specifications for the model we deliver, but even with all of those, there are many circumstances where nurses will find themselves in situations that are just not easily addressed by any particular protocol. And so the understanding of and the real-time application of these principles of person-centeredness, population relevance, reliability, robustness, anticipatory assessment and response, and accountability are ones that we practice when we do case-based learning reviews as to how to apply them in real time so that they don't become just mottos. Next slide. The practical specifications of the assessments and interventions that we've adopted into the model that nurses are trained on when they join the team is a pretty extensive list. So there are specific, what we consider to be best-in-class or most compelling evidence-based interventions that are preventive interventions. It's a wide array of things that range from various monitoring tools and assessments and screenings to lifestyle behavior change, medication reconciliation, lots of education of participants and family members about their chronic conditions and their self-management options and opportunities, lots of coordination with community resources and health system resources, and very close ongoing collaborations with primary care docs and specialists. Next slide. We took the concept of operational domains from implementation science, and these are listed here. The policies, procedures, and protocols are the sort of the nitty-gritty. You have to specify what you want the model to do, who does what, when, where, how, on what frequency, how will it be measured, etc. Staff education and training is really to ensure that staff coming on board, instead of just referring to dry policies and procedures, have a chance to understand the rationale for them, practice them, are trained by mentors who are very skilled in those activities, including role play and observed use of the approach with patients during a training period. There's a volume of materials that have been field tested for participant education and family member education that parallel and coincide with the key areas that staff are trained on around chronic condition management and best practice standards of care. And then there is a need to collect data from the field, both in terms of what the assessments and screening efforts are yielding from patients and their personal goals and aspirations, but also the activities of the nurses, the care coordination calls that are being made, the education that's being provided, and so on. And to collect that data and then to analyze it in a way that's specifically geared toward understanding whether the model is being reliably implemented in accordance with the design. Next slide. So we have created an IT platform because that's a lot to cover in those 5 domains. So our platform that we've developed and designed with support from HMetrics as our development partner, when you log into the start page, you see these 5 buttons in a web-enabled data system that allows you to access any one of these components of the 5 domains from a single point and get to those fairly quickly. And within each button, there's quite a robust set of information and material to support the work in each of these areas. Next slide. Here's an example of what I think is a more unique way of thinking about data analysis. We use a lot of statistical process control, charting, and other statistical analytics to try and look at variation in performance, either by region, payer contract, or in this case, individual nurse care manager. This is an example of a chart showing each dot being a nurse care manager's fraction of their caseload that had a abuse or neglect screening done as specified in our standards. And you'll notice 2 outlier dots. The very low one, about 50%, is a new nurse with 4 patients just ramping up their panel. No intervention needed there. The other dot is at 84%, which without statistical process control measures you might think is more or less in the ballpark of her peers. But it is a statistical outlier, and we use that to help do root cause analysis and drill down. And it turns out that that nurse was very uncomfortable with this particular task, which is a challenging and intimate task. And with coaching and support from the senior clinical lead, was able to overcome the avoidance for doing this and be reliable to her patients in screening them for abuse and neglect in the home. Next slide. So the results of all of this focused effort to create a holistic, very comprehensive, very a system that has a great deal of discipline design behind it, I'll summarize briefly in the next couple of slides. A lot of the results come from a randomized prospective trial that we were involved in with the Medicare Coordination Care Demonstration. Lasted almost 13 years and divided into 2 separate clinical trials in that time period, an 8-year initial trial and a 4-year trial, which we learned a great deal from both. Over 3,000 patients were randomized. In the first phase of the trial, we observed a 25% decrease in all-cause mortality for the group working with the nurse care manager. That was statistically significant. And randomization in this trial occurred at the individual participant level. So the physicians and practices participating had a roughly equal number of those getting usual care and those getting services from the nurse care manager. Because the initial phase of the trial, we enrolled low, medium, and high-risk people because we weren't sure where the various health or financial impacts would best be observed over time with a preventive model of this type. Subgroup analyses showed that folks in a what I'll call higher risk, by many people's standards, they wouldn't be considered very high or superutilized category, but for example, folks with either heart failure, ischemic heart disease, or chronic lung disease and 1 or more admission in the prior year demonstrated these impacts on reducing admissions, ER visits, and net savings after program fees, which were both statistically significant and notable in that was during an average follow-up period of about 42 months. So these were fairly sustained. Next slide. There are a number of peer-reviewed journal articles about our program and its impact that I won't go into here, but you can look at, and the takeaway just of those is that for the most part, folks that are in this moderately high to higher risk range can see these benefits with a model like this. These are publications that our partners at Penn helped us with, which was to look at how does this type of model work? What are some of the features and attributes and characteristics that really help make it be effective? One of those we explored together with our research partners at Penn was the long engagement, the durability of engagement of participants in the program. And we looked at both the quantitative and qualitative factors associated with that. And these articles are available for your reference, but the takeaway is that more frequent in-person contacts with a consistent nurse and the experience that people had of feeling like they had someone they could turn to without judgment or without embarrassment to ask questions that they had, and it was patient and supportive in an ongoing way. There are opportunities to learn new things and to socialize with others in our group programs, and just the sheer dedication of the nurses were things that kept people engaged in the program. Next slide. We also have experience having worked in Medicare Advantage, in this case over a 7-year collaboration with Aetna in Southeast Pennsylvania with 2,500 chronically ill adults they assigned to us based on their proprietary risk scoring models, which their medical economics unit evaluated using a difference in differences approach. These are results that they publicly reported in press releases in terms of the model's ability to reduce hospitalizations and hospital costs. Next slide. This one I want to take a moment to pause and reflect on a little bit. This is the long-term mortality impact that is the 12-year observation period of the Medicare demonstration project. So this is again, what would be considered the higher risk subgroup, not the extremely high complex, but moderately high to high. It includes those patients as well, but it's really important to emphasize this is not a single very narrow band of homogeneous risk. This is moderately high to high, multiple chronic conditions, usually polypharmacy, often a hospitalization or two in the last year or two, but not necessarily more a high utilizer or complex than that. And it's really important, again, to emphasize that this was a randomized controlled trial analyzed on an intention to treat basis, and these are actually analyses done by Mathematica Policy Research, which was contracted by CMS to look at these outcomes. So at 2 years post-enrollment or post-randomization, compared to the group getting usual care, those getting cared for by the nurse had 34% fewer deaths, all cause. And it's a fairly large sample size, over 1,100 randomized folks, highly statistically significant. At a 5-year follow-up time point, there was a 22% reduction in deaths, still very statistically significant. And the number needed to treat, for folks who are familiar with that term, is quite low. So if we had enrolled 19 people in the program and followed them over 5 years, would have resulted in 1 avoidable death. And the importance here is not to emphasize longevity as an end unto itself, but to emphasize that these results were obtained through a preventive model with no known side effects that also maintained independent function, quality of life, and was extremely well received by patients and family as being a very supportive essential help to them in their aging process. I think it's important to note these results because often we fixate on the financial outcomes only, and I think preventive models in general are burdened by the double standard of having to not only not cost much but save money, whereas you can imagine if these same results were from a drug trial with no known side effects, it's very likely that that medication would be approved and would be billable at a very significant amount of money. So we're struggling to make sure that these kinds of models have an opportunity to have an impact going forward. Next slide. Just very briefly, but this is very important. I don't want to give it short shrift, but I'll just note that our model does not work all the time in all settings, and it's very important to understand when models that have strong outcomes like ours don't work. We had the learning opportunity of a second phase of the Medicare demonstration trial where parameters were set for us by CMS that changed the way we identified the target population. The data we used for case finding dramatically shifted our risk band to a very narrow, high-risk subset of folks that precluded us from using some key elements of our model. and was also plagued with some disruptions and discontinuities of services because of administrative reasons. And when you take a model like ours and you have those factors at play, you don't see the results in terms of mortality or decreased utilization. So it's important to know how sensitive any of these models are to changes in their implementation and where adaptations can go a step too far in terms of losing effectiveness. Next slide, please. So this has led us to really focus on and personally being very interested and intensely involved in trying to understand how do we replicate and scale models of this kind, both ours in particular, but others that have these attributes of higher touch, higher intensity, preventive orientation. So I did my dissertation research for my public health doctorate on this subject of trying to find practical strategies. With colleagues at the Camden Coalition, we were able to publish a blog post on Health Affairs on this topic of replicating effective models. And for folks interested, I highly recommend, for those who haven't seen it, the February issue of Health Affairs, which is chock full of really interesting articles about the challenges of doing this. Next slide, please. Out of my research came this concept that we are now using at Health Quality Partners that we're calling Replication Consultancy. And it actually was suggested to me by a CEO of a health system that I was interviewing as part of my research, who described it as something that they would be interested in using as a way to adopt these kinds of more demanding, more rigorous models that are clearly a little more challenging to implement from scratch. And the concept was to have the originators of the model, in this case Health Quality Partners, help adopting organizations learn the model from a series of disciplined stages of orientation, from identifying the target population with them using their available data sets, geomapping that target population, modeling the staffing patterns that would be required to cover those populations in those geographies, integrating any data into the Sparrow IT platform to enable the organization to implement with the same protocols and 5 operational domain support that we've used over the years, and then to continue to monitor, support, and help develop the capabilities of that team to effectively implement the model, all the time measuring the adoption and the assimilation of the standards and protocols and the fidelity and variation of those implementations to see whether or not the uptake is successful, and to continually monitor but gradually wean off sort of the consulting part of the support once the adopting organization had ground under their feet and were able to implement this independently. So that's what we've been trying, and I think we're learning a lot. I think there's a lot of positive opportunities in this approach, and now I'm very pleased to turn the webinar over to Jonathan Harvey, a good friend and colleague who has been a champion at Martins Point Healthcare, where they have been adopting the model in partnership with us. Jonathan?
Well, thanks a lot, Ken, and I just want to share with the group that Ken and I met at a conference of an alliance of community health plans about 2.5 years ago. He shared the story of Health Quality Partners, and that began a conversation between our organization and his organization in terms of building a collaboration around replication at Martins Point. I'm a family physician by training. I serve as Chief Medical Officer here at Martins Point. I essentially oversee operations and quality, both in our health plans and in our practices. And while the title of my piece is Innovation in Complex Care Management at Martins Point, it's really about the component of our health quality partners in that complex care management domain. If you go to the next slide, please. So this is an overview of what I'm going to share with you, a piece around Martin's Point, a piece around our definition and strategy in care management, and then I'm going to spend most of my time on the last slide, which is highlighting our experience in replication, specifically with health quality partners and the relationship that's developed there over the last couple of years. So next slide, please. So Martin's Point is a 501c3, and we have a mission statement, which is leading our communities to better health through relationships built on trust. You've probably heard the expression 6 degrees of separation. Well, here in Maine, it's really 1 degree of separation, and relationships really matter in terms of our community. And so a big part of our mission is engagement and meeting community need, not only as a objective in terms of serving the health of populations, but an objective in terms of serving our brand and our trust in the local nature of healthcare here in Maine. Next slide, please. So to describe our organization, I would really suggest to you that we're two things. One, we're primary care and we're health plans. And we serve approximately 150,000 patient members. 80,000 of our patients are served in our primary care practices, and then another 80,000 in our health plans. Only about 20% of our health plan members are seen in our practices, but in that group of 20% of patients who are members, we have a tremendous opportunity to innovate, and this is one of the reasons why we found a relationship with health quality partners so compelling, is that we had a model where we could serve the community really in an extension of our primary care, and then using that model, we could actually extend the care delivery model into our network with an advanced preventative model that we believe would serve health outcomes in a much more meaningful way for our communities. Next slide, please. So foundationally, Martin's Point is really rooted in the triple aim. We spend a lot of attention measuring and reporting in experience, in total cost of care, measuring healthcare outcomes. Because we are a community-oriented organization, patient experience and engagement is really the primary focus for us as we begin new programs and as we begin new offerings in our community. And so you'll see as I talk through our relationship with health quality partners that there was a real connection around engagement for us in the model that Dr. Coburn and his team have designed, because only with engagement can you build the foundational pieces around a therapeutic relationship, which then help to drive those health outcomes in a way that is different and impactful in the communities that we serve. Next slide, please. We spend a lot of time here at Martin's Point thinking about the social determinants of health. You probably have all heard the expression that zip code is a more powerful determinant of health outcomes than either genetic code or medical care combined. And when we are assessing new approaches to complement the work that we're doing in the practices, we're really looking for approaches that get at those ecologic determinants that relate to factors such as social isolation, addiction, poor housing, poor transportation, all of the things that we know often underlie decompensation in medical conditions. And so as part of our triple aim focus, unless we are paying very close attention to those social determinants of health, we don't believe we can influence health outcomes in ways that the rest of the healthcare system is currently not meeting those objectives. Next slide, please. So this is a pictograph that will help me walk you through our approach to care management here at Martins Point. We have 7 primary care health centers. We've integrated traditional care management approaches with some newer approaches, including embedded care management in the practices and telephonic care management approaches. And we've also begun a much more sophisticated measurement process that allows us to build reliability. And so as we think ahead, building capabilities that can allow us to build predictable outcomes based on key processes becomes a strategic objective for us, and that was a key component in our decision to relate to health quality partners at a collaborative level. Next slide, please. So there were some really key components to drive us to adopt and build the model with Dr. Coburn's group. The most important piece for us was a cultural affinity in how our organizations wish to impact the communities that we serve. And so there was a real connection around values and mission that were the fertile ground upon which our partnership was begun, and I think upon which now our relationship is thriving. We have targeted a high-risk elderly population here in Maine because we are the oldest state in the union from a demographic standpoint, and our health plans are serving a very complex elderly population for whom the intervention of community-based nurses designed at Health Quality Partners felt like a really good fit. We also were intent on looking at clinical outcomes in a new way. Our health plans and our delivery systems really hadn't built a discipline around measuring outcomes in segmented populations, and the structure and discipline around the Health Quality Partners approach allowed us to have confidence that in 2 to 5 years we're going to be able to look back in an evidence-based way and prove to ourselves that our intervention is effective using some modern approaches. The approach that we plan to use is an applied science approach, and Ken can share more about this with you, but the whole idea of propensity matching and sophistication around measuring cohorts in a controlled way will allow us to make the case to ourselves and our board of directors in the long run that what we're doing to meet community need is also serving business objectives in the longer term. The data that we use, it feels a little bit like this is your father's Oldsmobile. There certainly are a lot of risk predictive models out there. I think what really struck us about the Health Quality Partners approach is it's using a fairly simple logic to define populations. And as we've gotten out in the field now with 80 members, what we've seen is the relatively simple model that was designed is really picking up on folks for whom intervention we believe is going to have a significant impact on their lives. The fifth area on this slide, and probably really important in terms of replication adoption of these models, is the sometimes brute force that it takes to achieve leadership buy-in around adoption and innovation. This really has involved executive leadership, my leadership, in bringing it to our board, bringing our executive team along, bringing our managers along in health plans and delivery system, and really getting in front of our physicians who, in fact, now are net promoters of the program, which then builds the traction around enrollment and membership, which we think is going to lead to significant growth in the near term in enrollment. And as I think about key learnings and insights, one of the key and early pieces of learning for us is the very high engagement rates that we're seeing. Historically, our health plans through telephonic approaches have had about a 5 to 20% engagement rate, and we're seeing a 55 to 60% engagement rate. Engagement being defined by essentially nurses being invited back for the next visit by members who we've outreached to. Another insight is really around the importance of staying true to design. We would really like to be able to attach key performance indicators in the design of the program to outcomes over the long term. And so we've been very, very focused as a leadership team on maintaining the integrity of the original design as we adopt in a new environment here in Maine. So that's all I've got. Happy to take questions. And just to end on one note, I was joking with Ken when he was up a few weeks ago that if I think about the relationship with health quality partners, there's really two things that need to work. One is the brain and the other is the muscle. And I think that Ken's team is really the brain and we're the muscle, trying to learn the muscle memory of a program that we think is going to have a huge impact in our community. So thanks a lot and happy to take questions.
Thank you very much, Ken and Jonathan, for your very informative presentation on the advanced preventive care model. We do have a few questions that have come in, and so I'll start with this question which focuses on replication in a rural county. So if this model was to be implemented in a rural county, who should hire and supervise the nurses? Is it a hospital or a community-based organization or primary care practices? Ken, can we start with you to share your insights on that?
Sure. No, it's a terrific question. And I think one of the things that I'm excited about is that I think that this model has the potential to be implemented and overseen by any number of organizations. For example, we've talked with county departments of health that have community nursing who are potentially interested. Visiting nurse agencies could also, be the locus of implementing this model. Health Quality Partners itself is kind of a standalone, nonprofit community organization. It could be, though, embedded in a health system, large health system delivery, and perhaps even in health plans. I think, Jonathan's experience with Martin's Point being so close to the actual delivery of care of patients, either as a physician group practice or as a health system or some other provider entity, seems to me to be the best place for this, as opposed to just isolated, in a health plan. But I think increasingly health plans are looking to provider systems to be the effector arms and implement these models anyway. So I think there's less of a division there. So answer is, long answer to, I think it could be in any one of those types of organizations.
Mm-hmm. Great, thank you. And along the same lines of replication, so if this model or a similar model were to be replicated in a resource-lacking environment, a health organization with very few resources wanted to start a program for high-risk, high-utilization patients, what would you say were some of the bare necessities for initiating the program? How would you prioritize the specific components for initiating a program like that?
Well, certainly the nurses are key. I mean, they are really the heart and soul of the model, and that's not because we don't think and don't leverage other disciplines heavily. And we actually have hopes of doing some further design and models of implementing a variety of other disciplines. But if you had to have a, pick your Swiss utility, all-purpose healthcare provider to help a model like this, it would obviously be, from our perspective, be the RN nurses. And then, to the extent that you can, I think you have to, even if you're starting small, you have to really try and build in the appropriate supports for that small team of nurses. We generally don't like to have any fewer than a pod of 3 nurses in one area so that they can cross-cover each other, support one another. And, you know, the next thing I would recommend is someone that's there to, you know, at a management level, presumably or ideally a very experienced nurse who knows the model to be their backup, mentor, and support. It's a very tough job. It requires a lot of the nurses, and developing the management systems to support them in the field and the data tools to help them do their work would be the next things I would add to a small implementation model.
Mm-hmm. And Jonathan, do you have anything to add to that in terms of the barest minimum components to start with?
I think Ken's right. You know, you do need there's a workforce piece here that requires sort of a minimum staffing. So starting with anything fewer than 3 nurses, a clinical lead, and a director would be challenging just in terms of coverage. I would say on the funding side that we have made the business case based on our health plan seeing improved quality outcomes and reduced total cost of care. And so there's a capitated basis to funding the program through our health plans that has helped us build a pro forma that's looking out, you know, 3 to 5 years as opposed to year to year. And so having that kind of conviction on the financial fidelity side really is important. The model itself is much more of a delivery model in its design, and so in terms of building traction, it is much more meaningful to primary care physicians than it is sort of traditional hospital systems. And so building traction really relies on the interaction and promotion of the program by primary care physicians who really, at least here in Maine, are embracing it.
Mm-hmm. Great. And Jonathan, a question for you. So you currently had mentioned that there are about 80 patients enrolled in the program. And so what, at full case, or what proportion, well, first of all, what proportion of your patient population is that? And if maximum number of eligible patients were enrolled in the program, what proportion would that be? And secondly, just following up on that question, a two-pronged question. Secondly, what is the caseload for nurses in terms of follow-up, the nurses who are actually having follow-up with patients?
Yeah, great question. So it's a question of scale and nurse caseloads. We built our pro forma to serve 600 members, building to 3 years using 13 nurses carrying a caseload of 70 to 90 patients per nurse over that time period. We do anticipate that if we see growth, traction, and outcomes in that member population of 600, that we would then consider further scaling the program to meet the needs of a broader population in the state of Maine than our initial pro forma was built for. But 600 members is about, if we run the risk-adjusted model, that would be serving probably around 10% of the folks that we feel could benefit from the program, but would give us a good run on outcomes over that first 3 years of intervention.
Okay, thank you. And I wanted to turn to a question that focuses more on perhaps building the business case for implementing a model like this. So I think one of the slides that you had showed, the results slides that you had showed, Ken, showed how the results were over a 12 or 14-year period. And so a follow-up question to that, on that particular slide, is is that the length of time that it would one would need to implement a program like this to actually see results, or can you just shed light on how you continue to kind of maintain momentum even in the initial phases of the implementation?
Sure. No, that's a great question. Gee, I'd be upset if I left people with the impression that it takes 12 years to see impacts. No, I was mainly emphasizing the long-term durability of the impacts on mortality. In terms of utilization and early favorable outcomes, admissions, readmission rates, and things like that, we started to see an impact at about 18 months. And by 18 months, I'm benchmarking that against when your team is fully up and running, right? So as Jonathan kind of has alluded to, it takes a while to do the recruitment, the training, getting systems in place. But when you've got a team going, what we first observed actually in the demo was we got early calls from CMS and Mathematica saying that they thought something radically wrong was going on because they saw an uptick in the intervention group for elective cardiovascular procedures that looked like it was tremendously increasing costs in the first 6 to 9 months. And we literally drilled down on each of those cases, and case by case, the nurses described going out to the home, seeing an older gentleman holding onto their mailbox, diaphoretic, gray, ashen color, feeling chest pressure, getting them to the ER, and sure enough, they needed, a stent or a cabbage or something. At about 18 months on, though, we started to see a big flip in that, and that the group that was not getting the nurses proactively identifying their under-addressed ischemic heart disease were showing up in the ER, in cardiac arrest, being resuscitated, spending a long period of time in the ICU, and from between 18 and 24 months, those results totally flipped, and there was a significant net savings and lower incidence of those kinds of complex long stays. So you can see results fairly early on, but you do have to put in that upfront investment to get the team up and going.
Okay, great. So we have time for maybe 1 or 2 questions. And so I will ask about the specific populations that you serve and the implication for replicating a model like this in communities that are perhaps socioeconomically disadvantaged or communities that are skeptical of the health system. So how do you build trust with the communities that you're serving, and in order to maintain continuity of care? Can you share from your organization's experience?
Do you want me to address that?
Sure, yes, we can start where you can.
Sure. Yeah, no. So the nurses, again, play such an incredible role in this, and they spend a great deal of time thinking about how to make person-centeredness not a buzzword, but a practiced skill around being non-judgmental, and techniques like motivational interviewing and other things are used. But it's a lot of patient as in taking the time to listen and be an active listener. And one of our favorite things is we do written surveys that we ask patients around their experience using the program, and the comments are always just extraordinary in terms of how much they feel understood. And that approach has really helped build trust across a diversity of ethnic backgrounds, socioeconomic status, all kinds of other things that might ordinarily divide people and leave them mistrustful, can be overcome by a real diligent commitment to that approach, to relating to them with a very respectful and considered approach.
Okay. And finally, Jonathan, do you have any parting thoughts? We're just about a minute from the top of the hour, so any final lessons that you want to share with the audience?
I would just say that what we're seeing early here in Maine is promising. from a replication model standpoint. We've got a long way to go, and we're glad to have a partner who is going to help us build a model that we think is going to have an impact on our community in a way that we haven't previously had an impact. And so we're in it for the long haul, and we've committed to the long haul. There's a lot of work around promotion of a new program, both in your organization and for the doctors in the community. But I think what we're seeing, at least early on, is that the systems are seeing huge gaps in care for patients who have complex needs, and we need better approaches to support better health outcomes. And programs like this are going to improve those outcomes by filling those gaps.
Thank you very much. I'd like to thank our featured speakers, thank our partner, Peterson Center on Healthcare, and thank all the participants today for just joining on this discussion. We have more resources on our website, as well as there's a registration link for the final webinar, which is coming up on April 25th with HealthShare of Oregon, focusing on effective care for children with complex care needs, as well as children in the foster care system. And you can also download the special publication on our website. Thank you very much again. Bye.
Thank you.